we're jumping straight into a really critical question for anyone in intensive care today. What's the right blood pressure target for patients in septic shock?
Right.
Specifically, we're focusing on mean arterial pressure, MAP, and drilling down on what the evidence says for older adults.
Yeah, that's really the core issue, isn't it? I mean, for a long time, the standard's been, well, 65 millimeters of mercury for the MAP target.
65, yeah, that's the number everyone knows.
Exactly. But, when you're actually there, managing a patient, especially someone who comes in with high blood pressure normally, chronic hypertension, you always wonder, is 65 really enough for them? You feel this push, maybe we should aim higher.
That's the instinct, right? And that specific feeling, that clinical question, is exactly what some key recent evidence looked into. So we're going to pull out the absolute must-know findings for you. What was the main research question they tackled?
Okay, so this was the OPTPRESS trial, and it looked exactly at that. They focused on adults, 65 and older, who were admitted with septic shock.
Okay, 65 plus septic shock. Got it.
And they basically asked, is it better or safer to really push for a higher blood pressure target compared to just sticking with that standard 65 goal?
So let's get specific on the numbers. What targets were they actually comparing in this trial?
Right. So there were two groups. The standard group, they aimed for a MAP between 65 and 70 millimeters of mercury.
Okay, 65 to 70, standard.
Then there was the high MAP group. They were aiming significantly higher, 80 to 85 millimeters of mercury.
Wow, 80 to 85. That really captures that higher target some clinicians aim for, doesn't it?
It absolutely does. It's right in that zone where people think, maybe this hypertensive patient needs this higher pressure.
And speaking of hypertensive patients, how many in the trial actually had chronic hypertension beforehand? Was it representative?
Well, very much so. About 2/3, roughly 66% of the patients enrolled already had diagnosed chronic hypertension.
Okay, so this wasn't just a general elderly population. It really included that specific subgroup we worry about.
Precisely. These were the folks where you'd traditionally think, okay, maybe they need that higher perfusion pressure.
And how long did the teams have to keep the patients within these target MAP ranges?
The protocol was pretty clear. Maintain those goals, either the standard or the high one, for up to 72 hours.
72 hours. So covering that critical initial phase of managing septic shock?
Exactly.
Yeah.
Right when things are most unstable.
Okay, let's pivot from the setup to the results. This is the crucial part for practice. The main thing they looked at was 90-day mortality. What was the death rate in the standard group, the ones aiming for 65 to 70?
In that standard MAP group, the 90-day mortality came in at 28.6%.
Okay, 28.6%. Still high, which, reflects how serious septic shock is in this age group.
It does. It's a tough diagnosis.
Now, for the key comparison,
No.
what happened in the group where they pushed the MAP higher to 80 to 85? Did that extra pressure translate to better survival?
No, not at all.
Yeah.
In fact, it was the opposite. That high MAP group had a significantly higher 90-day mortality rate, 39.3%.
Wait a minute. 39.3 versus 28.6. That's over a 10% absolute increase in mortality.
That's right. A 10.7% absolute difference. It was stark.
So aiming higher wasn't just neutral, it was actively harmful. Did the trial even finish seeing results like that?
No, it didn't. The Data Safety Monitoring Board recommended stopping the trial early.
Wow.
Specifically because of that signal, the clear evidence of increased harm in the group getting the higher MAP target.
Wow. When a trial gets stopped for harm, that sends a really strong message.
It's about as definitive as evidence gets in medicine. It means the risk clearly outweighs any potential, or in this case, non-existent, benefit.
Okay, but what about those hypertensive patients? That was the whole reason for thinking higher might be better, right? Did they see any benefit from the 80-85 target? Maybe the overall result masks a benefit in that subgroup.
That's what you'd hope. Maybe. But no, the analysis was clear. No subgroup, and that includes the patients with chronic hypertension, showed any benefit from targeting 80 to 85.
No.
None. They experienced the same increased harm as the overall group.
So that completely flips the script on that old idea that hypertensives need higher pressures in shock. The data just doesn't support it. It actually shows the opposite.
Exactly. The evidence directly contradicts that long-held belief. And the price for following that belief, in this trial at least, was higher mortality.
Okay, death is the ultimate outcome, but what about other things? Organ function, particularly the kidneys. We always worry about kidneys and sepsis. Did the higher pressure maybe protect the kidneys, even if it didn't save lives overall?
Yeah, that's another critical question, but unfortunately the answer is still no. The high MP group showed zero improvement in overall organ function or any of the secondary outcomes they measured.
Zero improvement. And for the kidney specifically?
Actually, looking closely at renal outcomes, the high MP group had fewer renal replacement therapy-free days.
Fewer RRT-free days, so that means they needed dialysis more often or for longer.
Correct. It points towards worse acute kidney injury or at least slower recovery in the group that got the higher MAP target.
That's really counterintuitive. Higher pressure leading to worse kidney outcomes.
It seems that way. It really hammers home that the high target wasn't just failing to help, it might have been actively contributing to organ dysfunction too.
So why? What's the thinking behind this? Why would pushing the blood pressure higher lead to worse outcomes, including death and kidney function? It feels backwards.
Well, the likely mechanism isn't really about the pressure number itself, but how we achieve it.
Okay.
To get an MAP from, say, 65 up to 85, especially in septic shock, you have to use higher doses of vasopressors, usually norepinephrine.
Right, you're cranking up the pressors.
You're cranking them up, and those higher doses, they come with their own baggage. They have known side effects.
Like what?
Well, excessive vasoconstriction, for one. While it boosts the central MAP, really high doses can clamp down too hard on blood flow to other areas, the gut, the fingers and toes, and potentially the kidneys.
So even though the main pressure reading is high, the actual flow to vital organs might be compromised by the drug itself.
That's the concern. You might be sacrificing peripheral and organ perfusion to hit that central number. Plus, higher vasopressor doses increase the risk of other serious problems, like arrhythmias, abnormal heart rhythms.
I see. So it's the cost of achieving the higher number, the drug side effects, the potential for reduced organ blood flow despite the high MAP that's likely driving the harm.
That appears to be the most compelling explanation, yes. The toxicity or adverse effects of the higher vasopressor doses required seem to outweigh any theoretical benefit of just having a higher number on the monitor.
This is incredibly important stuff. Okay, let's boil it down. For the clinician listening right now, managing an older adult with septic shock, what is the single, clear, evidence-based takeaway?
It's really straightforward now. A mean arterial pressure target of 65 millimeters of mercury should remain the standard of care.
Stick with 65.
Stick with 65, or perhaps that 65-70 range they used in the standard arm. This approach is associated with lower mortality compared to pushing for 80 to 85.
And let's just underline this again. Even if that patient sitting in front of you has a history of chronic hypertension.
Yes, even then, the evidence showed aiming for higher MAP goals increases the risk of death and provides no measurable benefit, not even for hypertensive patients.
So that internal voice saying, push it higher for this hypertensive patient, we need to resist that urge based on this data.
We absolutely do. The burden of proof has shifted dramatically.
Yeah.
You need a very, very compelling patient-specific reason to deviate upwards from 65 in this population.
Okay. So building on that, what's the final question this knowledge should prompt for every provider out there managing these patients?
I think you need to ask yourself this. Setting aside truly unique situations, maybe someone with known severe carotid stenosis, where flow is pressure-dependent, documented issues like that.
Right, very specific cases.
Outside of those rare exceptions, what objective data point, what finding in your specific patient would actually justify overriding this strong evidence and pushing that MAT target up towards 80 or 85? Because the default, based on OPTPRESS, has to be 65. The evidence supporting deviation needs to be incredibly strong.